Welcome to Last Breath Diaries. Thank you for joining me this evening. Before we dive into tonight's story, pour yourself a drink, sink into your favorite spot on the couch, let the world fade away, take a deep breath, get comfortable, and settle in. Tonight, we step into the shadows and into the story. Welcome back to Last Breath Diaries. Tonight, we return for part 3 of When the Air Turns Thick, the unseen killer of pulmonary hypertension. In the last episode, the fight for Tommy Reed's life came to an end. Despite every measure, every desperate attempt to restart his failing heart, the monitor fell silent. The team called the time. His story, one that began with breathlessness and hope, closed with a stillness no one ever gets used to. What came next wasn't chaos. It was quiet. The kind of quiet only hospitals know after a code ends. Those who were there say the room didn't fall silent, it just changed its sound. The rhythmic beeps of life support faded, replaced by the hum of machines winding down. The echo of footsteps leaving the trauma bay carried the weight of everything that had just happened. Tommy's body lay still beneath the harsh fluorescent lights, a man who had fought until his very last ounce of oxygen was spent. His chart now bore 3 words that always hit like a punch to the gut: time of death recorded. The nurse who cared for him said that moment, removing the ECG leads from his chest, shutting off the monitor, never stops feeling sacred. You're not just cleaning a room, you're closing a story. Hey, nurse chat, let's pause for a second. When a patient passes away, nurses perform what's called post-mortem care. It's a final act of dignity, removing medical lines, cleaning the body, preparing it for the family's final goodbye. It's not routine, no matter how many times it's done. Every patient becomes part of you, even after the heart stops. Tommy's wife, Lisa, was brought back to the room after the code team cleared out. She didn't speak at first. Grief rarely announces itself, it just spills. She reached for his arm, pressed her face to his sleeve, and whispered, "You can rest now." Those who witnessed it said it was one of those moments that stops everyone around. You could feel years of love and loss colliding in that single breath. A newer nurse standing nearby asked quietly, "How do you do this and not fall apart?" The seasoned nurse she asked just said, "You don't. You just learn how to carry it." And that's the truth most people outside these walls never see. Hey, nurse chat, here's what happens behind the curtain. Even after death, the charting doesn't stop. Every round of medication, every compression, every second of that code is documented. It's called a code summary. It's factual, clinical, but the hardest part is typing the words "unsuccessful resuscitation." You can feel the weight of it behind every keystroke. Name, age, diagnosis, time of death, a life, reduced to lines on a form. Lisa later thanked the team. She said, "You didn't give up on him." And that's the kind of thank you that stays with nurses long after the shift ends. Because we don't stop fighting until there's nothing left to fight for. When the night quieted again, one of the nurses stepped outside. The hospital lights flickered against the wet pavement, and she said she could still hear the echo of the monitor in her head. Phantom beeps that haunt you after every loss. Hey, nurse chat, let's talk about something that doesn't get enough light: post-code fatigue. It's what happens when your body comes down from that adrenaline high, when you've been running on instinct for 20 minutes and suddenly the silence hits. It's not just exhaustion, it's emotional residue. You replay the moments over and over, wondering what you could have done differently, even when you know you did everything right. That's the unseen side of saving lives. Sometimes it's surviving the losses. Later that night, someone found a small note left on Tommy's bedside table. The handwriting was shaky but clear. It read, "You fought until the air gave out." And maybe that's all any of us can really do. If you've been with us from the beginning, you already know how Tommy Reed's story ended. Quietly, tragically, after a long fight against a disease that most people don't even realize can kill. In Drop 1, we walk through those last moments: the silence after the code, the post-mortem care, the charting, and the emotional gravity that lingers when the room empties, but the air still feels heavy. Now we shift focus. Tonight's part isn't just about how Tommy died, it's about why. Because what happened inside his body was more than failure. It was a slow suffocation from within, disguised as shortness of breath. They say pulmonary hypertension is a quiet disease. It doesn't shout, it whispers, through the kind of fatigue people mistake for being out of shape, and through the swelling ankles that most chalk up to salt or long days. That was Tommy's first symptom, fatigue that didn't make sense. He was 37, healthy, active, worked construction, lifted heavy loads for hours. Until one day, walking across the yard left him winded. At first, he brushed it off. Then he started coughing, not much, just enough to notice. And soon, climbing stairs became a negotiation between willpower and breath. By the time his shortness of breath drove him to a doctor, the damage was already deep-rooted. His heart was fighting a losing war against the pressure inside his lungs. Hey, Nurse Chat, let's unpack what that really means. Pulmonary hypertension, or PH, isn't just high blood pressure. It's a condition where the arteries in the lungs become narrow and stiff, forcing the right side of the heart to pump harder to get blood through. Over time, that constant strain causes the right ventricle to enlarge, weaken, and eventually fail. That's why Tommy's heart didn't quit because of a heart attack. It quit because it was simply overworked. Imagine running a marathon uphill forever. That's what his right ventricle was doing. In the hospital, his medical team had tried every treatment available. Medications like epoprostenol, oxygen therapy, even vasodilators meant to relax the pulmonary vessels. But for some patients, no matter how early the intervention, the disease advances relentlessly. And that's the cruel irony of PH. You can look fine, even moments before your heart gives out. The autopsy confirmed what the team already suspected. Tommy's pulmonary arteries were thickened, scarred. The tissue had become rigid, leaving almost no room for blood to move through freely. His right ventricle was dilated, the muscles stretched thin from years of fighting back pressure it was never meant to face. The pathologist noted end-stage right heart failure secondary to idiopathic pulmonary arterial hypertension. Idiopathic, meaning no known cause. Sometimes it just happens. No lifestyle to blame, no choices to regret, just bad biology. Hey, Nurse Chat, here's something you might not know. Pulmonary hypertension can go undiagnosed for years. By the time symptoms become obvious, about 75% of patients are already in advanced stages. What's worse, early signs mimic conditions like asthma, anxiety, or simple deconditioning. So people are often misdiagnosed until their bodies are already in crisis. That's why nurses, especially in emergency and cardiac care, must think beyond the obvious when a patient says, "I can't catch my breath." Tommy's case became a lesson for many, a reminder of what can hide behind common symptoms. The nurses who treated him say they've never listened to a patient's breathing the same way again, because every faint wheeze or labored sigh could be something far more dangerous. In the weeks that followed, his name echoed quietly through the unit. Not because of how he died, but because of how much he taught everyone while he lived. Hey, Nurse Chat, let's talk about something that's rarely addressed, the emotional echo of a patient's death. In nursing, we call it carrying ghosts. Every patient leaves a mark, some soft, some deep. It's not about trauma, it's about memory. You remember the sound of their voice, the smell of their room, the way their family said thank you when words weren't enough. And over time, those memories become lessons you carry into every future patient. You learn when to push harder, when to stay quiet, and when to just hold a hand. In Tommy's case, the staff who worked that final code reviewed every moment in the following days, not to assign blame, but to understand the progression. They traced the timeline of his decline, the subtle swelling in his legs, the faint blue tint around his lips after minimal exertion, the way his oxygen saturations dipped unpredictably, the increasing fatigue despite aggressive therapy. Each sign, in hindsight, was another step toward the inevitable. And that's the haunting part. In medicine, hindsight is often the loudest teacher. One nurse described it perfectly, open quote, "Pulmonary hypertension doesn't steal your breath all at once. It just slowly takes the distance you can walk, the words you can say, the air you can keep, until one day you've run out of everything but time," close quote. That quote became something of a quiet mantra in the department, A reminder that no matter how advanced the technology, there are still limits the human heart can't outwork. Hey, Nurse Chat. Quick education check. There are 5 types of pulmonary hypertension, each with different causes. 1. Idiopathic or genetic, group 1, like Tommy's case. 2. Left heart disease, group 2, caused by problems in the left ventricle or valves. Lung diseases, group 3, COPD, sleep apnea, or fibrosis. 4. Chronic blood clots, group 4, unresolved pulmonary embolisms. 5. Other systemic causes, group 5, like sarcoidosis or blood disorders. Early detection saves lives, but only if someone knows what to look for. That's why patient education and nurse advocacy are critical. By the end of that month, the room where Tommy had spent his final days was reassigned. New patients came, new charts filled the rack, new lives hung in the balance. But for the nurses who'd heard his story, his name never left their shift reports. Because every nurse knows, there's always that one patient whose story sticks to your scrubs long after you clock out. In the previous segments, we followed Tommy Reed's final moments, the relentless progression of pulmonary hypertension, his collapse, the code that could not save him, and the quiet aftermath in the hospital room. We traced the clinical signs, the medical interventions, and the lessons nurses carry long after the monitors go silent. Now we reflect on what his story teaches, not just about a disease, but about the fragility of life and the resilience of those who watch over it. Even as a narrator recounting the story, it's impossible to separate emotion from the facts. Pulmonary hypertension is a thief. It doesn't rob you violently. It robs slowly, invisibly, until the very organs tasked with sustaining life can no longer keep pace. Tommy's right ventricle had been pumping under immense pressure for months, stretching and weakening until the final collapse. Every symptom he showed, fatigue, shortness of breath, fainting spells, were warnings the body screamed, even if they went unrecognized. Hey, Nurse Chat, consider this. One of the most critical aspects of caring for PH patients is oxygen management and monitoring right heart function. Right heart failure often goes unnoticed because the left ventricle can compensate temporarily. Nurses track oxygen saturations, monitor for swelling, measure daily weights, and watch for jugular vein distension. These small signs help determine whether the patient is deteriorating, even when outward symptoms seem mild. Tommy's case demonstrates why constant vigilance is essential, because early interventions can prolong life, even if the disease cannot be cured. The hospital team documented his progression carefully. Each step, each therapy tried, each dose of medication, the charts reveal a story of both perseverance and inevitability. Oxygen therapy was maximized, yet saturation still dipped unpredictably. Vasodilators were titrated carefully, but his heart could not keep up. The medications prolonged life slightly, but each day required more effort to maintain stability. Even in hindsight, every decision was made with care, and yet the outcome remained tragic. Hey, Nurse Chat, here's something nurses know deeply. End-of-life care in the ICU is a balance of aggressive treatment and humane recognition of limits. When interventions are no longer improving outcomes, nurses become guides, helping families understand what's happening and ensuring comfort for the patient. PH is progressive and irreversible in its advanced stages. Even with the best interventions, some patients will not survive. And acknowledging that is part of being an ethical, compassionate healthcare provider. This is a truth often misunderstood outside the profession. Not every fight can be won. Some battles, like Tommy's, end in loss, and the lesson is in the care, attention, and humanity given along the way. The nurses who recount Tommy's story emphasize the lessons he leaves behind. Never ignore persistent shortness of breath, even in active, healthy adults. Early referral to specialized centers can slow progression. Recognition of subtle signs by family, friends, and nurses can be life-saving. Even though he did not survive, his case is a roadmap for others, a story that might save another life because someone listened sooner. Hey, Nurse Chat, physiology check. At the cellular level, pulmonary hypertension causes the pulmonary arteries to stiffen and narrow. The right ventricle works harder to pump blood through these constricted vessels. This increases wall stress and oxygen demand. Eventually, the ventricle dilates, contracts less efficiently, and systemic perfusion falls. Patients may develop ascites, peripheral edema, and hypoxemia, all signs that heart and lung function are critically compromised. Tommy's story is textbook in its progression, a reminder that pH is a silent killer until it is too late. From a broader perspective, the case highlights the human element of nursing. We witness life, we intervene, and sometimes we fail, not because of lack of skill, but because some conditions are beyond our control. Nurses carry these memories, the sounds, the smells, the subtle signs, as part of their professional conscience. They remind us why vigilance, empathy, and education are crucial. As we close Tommy's story, consider these 3 final questions to carry with you. 1. How can families and healthcare providers better recognize the early signs of pulmonary hypertension before it becomes fatal? 2. What does it mean to truly honor a patient's fight when medicine cannot save them? 3. How do nurses cope with loss while continuing to provide life-saving care to the next patient? Thank you for tuning in to Last Breath Diaries. Please like, comment, share, and subscribe, and turn on your notification bell so you never miss a single story that might save a life. And remember, sometimes the most dangerous enemies are the ones you can't see, the ones that steal quietly until the air turns thick.